The views and opinions expressed on Coffee and Compatibility are those of the podcast host and do not necessarily reflect the official policy or position of ASHI.
Welcome, everyone, to another episode of Coffee and Compatibility. With me, as usual, is Dr. Kelly Hitchman. How are you doing, ma'am?
Excellent. Outstanding. I am so excited about today's episode.
Legend!
So
Yeah,
excited.
it is kind of a big moment for us.
So excited. I wanted to tell our listeners, Jeremy is with us in spirit. He had to jet off momentarily to go deal with a CLIA inspection of his laboratory, but he will be with us later in the episode today. But he's missing our fun for the introduction. And it's too bad, too, because we have so many exciting things to impart to you today. One, so important. I want to remind everybody that every year, the American Society of Histocompatibility and Immunogenetics sponsors awards to recognize outstanding scientific accomplishments, service to our great society, significant contributions to the field and others. We have a list of awards that are given out at the annual meeting every year, including the Marilyn McQueen Rising Star Award, the Distinguished Service Award, the Bernard Amos Distinguished Scientist Award, the Rose Payne Award, and the Outstanding Technologist Award. All of these are so important to lift up our colleagues and show them that their achievements and their efforts are so important to our society. I'm sure all of us know people that we think of when we think of these awards and know that these people are so deserving of our consideration. So please, the nominations are officially open for this year's awards. And ASHI is ready to accept nominations from you. You can reach out by the deadline of May 19th to Jenna Hoffman with ASHI, or you can email ashi-hla.org and nominate an individual that you know is so deserving of one of these awards. It's a massive honor to be nominated and to win one of these awards at the annual meeting, and a very exciting part of our annual meeting. So don't forget to put your nominations out. The deadline is going to come so fast. May 19th, email Jenna Hoffman with our ASHI staff or ashi-hla.org.
I mean, I think it's such a critical part of what the society does is, recognizing, the volunteers that do all of this for so many years and the people just starting, right? Like we have often touched on where we started and got to these areas and, recognizing the rising stars or the next generation of the society, I think is a super important aspect. And, one of the things that we've been touching on a number of times is subscribing to the YouTubes.
Get on the YouTubes.
Apparently it's a thing. That's what
It's
the kids.
pretty popular right
yeah,
here.
apparently it's a thing, right? And so we were talking, and we decided that we should have some fun with this. Shocker, right? We don't do anything fun. And it should be a drawing contest for all of the YouTube subscribers. If you have subscribed by, I don't know, first week in August, then any of the subscribers by that time, there will be a random drawing, and the winner will receive. Look at Kelly's face. It's like
a puppy.
Awesome. This is like, ooh, a puppy. That would be awesome. No, we can't do a puppy. I feel like there's probably a reason why we can't do that.
Yeah,
but
that's
we can do free annual meeting registration. So subscribe to the YouTube channel, become a subscriber, watch our faces on your devices, because why not? And get free annual meeting registration.
That's amazing. That is a huge prize. The meeting registration is, I would put a dollar amount to it because there is a dollar amount to it, but it is worth so much more than that. Attendance at the annual meeting gives you access to leaders in the field, colleagues, the latest research, collaboration, answers to questions about what other people are doing in their labs, what you're doing in your lab, chances to share. It's absolutely invaluable. What an opportunity. And for the low price of subscribing to the ASHI YouTube channel, I think it's a pretty good opportunity. So yeah, go over to YouTube and hit subscribe today. You'll be automatically entered into that drawing, and we will make a special announcement of the winner in August. That's great. So I can't contain my excitement any longer. I've got to transition. We are going to have a conversation today that is just full of insight that you don't want to miss, because today we are joined by a true leader in our field, a former honoree of one of our annual ASHI awards, Dr. Stanley Jordan, who is absolutely revolutionary in the area of transplantation biologics, working in so many clinical trials and so many fascinating studies. So stay with us. It's going to be a really good one today. I'm going to fan myself the whole time. We'll be right back after the short break.
Renew your ASHI membership and continue accessing career-boosting benefits like certification opportunities, professional networking, and exclusive discounts at ASHI events. Stay informed, stay connected, and keep advancing your career in the HLA field. Don't miss out. Renew today at www.ashi-hla.org.
Welcome back, guys, to what I consider to be a momentous episode of Coffee and Compatibility, because our guest today is the Dr. Stanley Jordan, who, as many of you I'm sure know, is an absolute pioneer in transplant immunology, whose groundbreaking work has transformed care for highly HLA and ABO incompatible sensitized transplant recipients, from developing the first desensitization protocols to leading landmark clinical trials. Dr. Jordan's innovations have paved the way for life-saving therapies used worldwide. He's currently the director of nephrology and transplant immunology and director of the kidney transplant program at Cedars-Sinai Medical Center. Dr. Jordan, it's an absolute honor. May we call you Stanley, even though I don't know if I'm going to be able to do that.
Well, thank you so very much. No, I thank you for that kind introduction. You can call me whatever you want to. I think Stan is what most people call me. So, but it's an old school name. But thank you so much for your kind introduction, and I'm really excited to be with you guys today and talk about HLA and desensitization and a lot of the new areas that are developing in kidney transplantation, where sensitization is really going to be a prime focus.
Thank you so much. Yeah, I'm now, with your permission, going to go to every meeting and tell them I just had a casual conversation with Stan the other day. It's going to make me look great. And leading into the first question, we have had the opportunity on a few occasions to have a few patients on the podcast. One of those being a patient physician, Dr. Bob Montgomery. And yeah, we have talked very specifically with a lot of those people about the delicate balance of their life after transplant with this transplant gift, but also the impacts of immunosuppression, which preserve the graft and are absolutely, necessary in so many cases, but also come with their own complications. As a pioneer in development and clinical trials for immunosuppressive medications and desensitization regimens, how do you view the experience that your patients have and this balance of the gift that is immunosuppression, but the complications that come with immunosuppression?
You know, that is an extremely important question and something that we think about a lot. And to put it in perspective, if you look at current immunosuppressive protocols, they're now more than 30 years old. And we've really not had any innovative ventures into transplant immunology for a long time. And patients do suffer a lot with these medication side effects. And I'm sure Dr. Montgomery spoke about that. And we see it, neurologic problems or kidney injury long-term with tacrolimus, patients with chronic diarrhea that can't be solved. So one of my major focuses, at least for the rest of my professional career, is trying to understand how we could develop novel immunosuppressive protocols that would be less toxic and more immune modulatory than immune suppressive. And one of the things that we saw with one of our clinical trials with a drug called clazakizumab, an anti-IL-6 drug in highly sensitized patients, is that we used the drug, it was a sub-Q shot monthly after pheresis and an IVIG shot, and this has been published in AJT a couple of years ago, where we had 20 patients and eventually transplanted all of them because we're able to see that giving it monthly for about 6 months after that initial treatment, antibodies were reduced. But I think what we did, maybe by serendipity or just by luck, is that we continued the drug after transplant. And what we saw is that we did not see rebound of the antibodies, and that when we looked at immune cell subsets over time, after about 4 to 6 months, we saw big increases in regulatory T cells in these patients and very little rejection. Only one patient had a DSA at 12 months. So what we saw there is that we're modifying the immune system in terms of increasing Tregs. We know that anti-IL-6 therapies can do that. And there were 4 of those patients we went on to convert to belatacept because they had problems with CNI toxicity. And we now have them out more than 5 years. No cyclosporin, no CellCept. And we have had really no rejections, excellent graft function. So we're very excited about that. We presented that as an abstract last year in Philadelphia at the ATC. So we'd really like to see interest from companies to explore therapies like this, where we could modify immunity, take away a lot of the side effects, and have patients get maybe 2 shots, hopefully sub-Q monthly, as their immunomodulation, I would call it now, because and then we can, we do have the power in our labs to monitor regulatory T cells and certainly antibodies and these sorts of things. But I think it has to be done in a very controlled way so that we can verify this. But we didn't report this for 4 years, so we want to make sure these people were doing well. And the longest one out is now more than 7 years on this treatment. So I think people have, if you look at a lot of these biologic agents in some of the trials, like in glomerulonephritis, they treat for 6 months and stop. Well, it goes back up. The antibody, you've got to find something that's tolerable and persistent, and obviously you want to make sure you don't get infections. But I think this is doable, and that we could move to this type of scenario, hopefully not too far in the future, because these are drugs that are available to us today.
No, yeah, I think that you've done some really great work pushing these desensitization protocols forward for our patients. And you touched on something I think is really important, is the connection between the desensitization therapies and protocols that you guys are doing, and being able to have some sort of like laboratory measure, understanding metric of what's going on in that immune modulation. And you mentioned like T regulatory cells, I heard you mention, and donor-specific antibodies. I'm curious to hear your thoughts on how or what role can, labs play in helping individuals like yourself sort of continue to push this boundary forward.
It's absolutely critical, because I think we, with the testing platforms we have that are so good now, that for every patient, I think if we can build that in as monitoring, their immune status. We do it in our lab, our transplant immunology lab, where you have people that, with recurrent infections. We look at their T cell function. We look at viral specific T cells and try to modify their immunosuppression based on those things. And I think, and on the other side is, okay, there, if we see good Tregs, and one of the things that we based, we found sort of, again, serendipitously in the belatacept plus anti-IL-6, there were animal studies, and actually I reviewed one of the papers that was in Nature Communications this year, and one earlier, were showing that in animal models of heart transplantation, that combining those two gave tolerance. And it was associated with increasing regulatory T cells and also decreasing CD8 effector T cells. Now, one of the things that's been a big problem with belatacept is that you get a lot of rejection early. It cannot be used early after transplant. And I don't think anybody really knew what was going on with that early, and we had a lot of problems with it. But now we know that it doesn't work against those CD8 T effector memory cells. And one of the things that we looked at, our four patients, we saw they were gone. And then the animal model is the same thing, that IL-6 not only modifies antibody, it is a very powerful inhibitor of CD8 T effector cells. So combining the two, you really get a good modification of effector functions against the allograft. So this is going to be critical. I think if we look at these things with labs, partner with our transplant HLA labs, immunology labs, that this, I think, is going to be very important for future management of patients.
So many of the things that you just said are really, really important, but I want to hone in on one thing that you just said, which is really interesting, because I feel like this happens a lot, certainly in transplant immunology, but immunology in general. We're looking to solve a certain problem. We apply a certain solution, and we find that that certain solution doesn't completely solve the problem because there's a backdoor method, especially with our tricky immune system, in circumventing our work and finding another way to exact its efforts, right? So like forever and ever, we want to use rituximab, but we know that rituximab doesn't hit all the B cells. And you just mentioned belatacept. Well, I'll go Bella to keep it easier on my tongue. Bella not being useful for CD8 T cells, but you can use IL-6 inhibitors or blockers with the CD8 T cells. So we know these things, and these things are in the literature, and there is more literature accumulating about companion therapeutics all the time. But I still see, and I know it's not just like from my personal center purview at a lot of centers, we tend to do the same things all the time with most patients. So why do you feel immunotherapeutics and transplantation isn't developing towards more standardized protocols for certain patient contexts? And our patients are they're super diverse. I get that. But if we know these things that you're talking about, why don't we suggest nationally an IL-6 Bella combination post-transplant therapeutic regimen?
Yes, I agree with you. I think that one of the things that we looked at and we want to be careful about, we see that there is a need for these types of therapies. And one of the trials that one of my colleagues, Dr. Heger at Cedars, now is involved in with NIH is looking at eplet matching. And those that have good eplet matchings will be randomized to a betacept, which is a sub-Q form of Bella, and be monitored. So I think this is really a good start to see how these patients will do being converted. And we know we can convert patients off of the CNI medications after about 6 to 12 months without getting all that rejection. So we're not really sure why that is, but early on you can. So I think this will be a very good first start. From my standpoint, I agree with you. And one of the things that we wanted to do in the patients we had, we're dealing with the most difficult patients. These are patients that were all highly sensitized, underwent desensitization, high risk for antibody rejection. CPR is, greater than 90 to 100%. Most of them are 100%. And you put them on this protocol and they do well. So I think if it works in that scenario, then one could assume that it would be very good for people who are not sensitized, and that would potentially could avoid the long-term effects of tacrolimus toxicity and potentially CellCept as well. So I think that what you said makes a lot of sense to have a collaborative type approach. And I mean, sometimes it's very hard because we have to get companies interested, but these are drugs that are already available and have been FDA approved, except for clazakizumab, but we do have Actemra, which works very similarly.
Dr. Jordan, I'm curious if you think that there's anything that we in the HLA community, that HLA laboratories can be doing differently or be doing better that could potentially help you more on the clinical side and improve care for our patients ultimately.
Yeah. Well, I think you do a lot, and I'm deeply appreciative of our HLA labs and just really all they bring, not just for saying no or go, for transplants, but I do think that evolving platforms, cell monitoring, like immune cell subsets or cell functions that we can look at by flow cytometry is a very powerful tool. And I think that trying to profile patients' immune status, pre and post transplant is going to be very, very helpful, especially as we evolve this novel therapeutic approach, because we really want to know what we're doing and if it can be sustained and is effective, other than just looking at the creatinine. Things that, in some of the studies now coming out with treatment for antibody rejection, one of the things that I like is and we use a lot, is the donor-derived cell-free DNA testing platforms. And I think for antibody rejection, it's pretty good. And in the paper that was in New England on felzartamab, which is an anti-CD38 for treatment of antibody rejection, you could see it really was very predictive of the drug efficacy. So we need to put our heads together and think about how we go forward with, with studies and to monitor patients so that we do it carefully. But there, the labs are critical, and I think, and also for HLA to expand it, to more cell monitoring and looking at effector cells, looking at regulatory T cells, and it'd be nice if we could do our own cell-free DNA too, but that's not there yet.
I want to ask how you feel about differential approaches. So there are certainly folks out there who want to just go the route of immunosuppressive reduction through tolerance induction. How do you feel about that approach? Do you feel like one approach is further along than another, more valid than another? How do you feel like we should be utilizing those approaches when we hear about both of them?
Yes, I think that's a very, very good question. And I think that, we have not done the tolerance induction protocols. I know that they're being done at several centers, but I just really think that's a big goal, and to get a patient where that they don't need immunosuppression at all. And of course, many of these patients have been well matched. So getting it where it's, where you have patients that are, receiving deceased donor, not well matched transplants, and trying to achieve that, from my standpoint, we know over years, if we don't have immunosuppression, they're going to eventually reject. And certainly monitoring them is going to be very important there. We did see one patient many years ago who was in the Mass General tolerance induction protocol, bone marrow transplant from mother. And a patient showed up with some proteinuria and high creatinine and had no T cell MLR positivity. to the mother. But we checked DSAs, or were really strong DSAs. So I think what we worry about in that situation is that you get maybe a split tolerance. Maybe you don't have it. You may have it at the T cell level, but the B cells are still avid and injuring the kidneys, and you get antibody rejection. So there we have to be very careful about the monitoring tools that we use. So not just look at the T cells, but the B cell antibody profiles as well. It's very powerful tools. So I think that needs to be clarified going forward. For me, I like the idea of just immune modulation right now. I wouldn't call it tolerance, but something that we could do and we can monitor, and hopefully would give us long-term benefits with simplification of the therapies to 2 monthly doses.
So I want to ask the last question, going kind of big picture, the future direction. And so, you touched on some of your colleagues using eplets to like stratify immune modulation. And, within the HLA community, there's still we'll say an active debate about HLA immunogenicity and what eplets matter, don't matter. All of those sorts of conversations are still, to be determined, if you will. And I'm curious to hear your thoughts on, is there, or do you see a role for sort of changing how we allocate organs with the idea, or incorporating the idea of immune modulation as part of that process? And by that, I mean, if you're see a future where I receive an organ from an individual and we have a good sort of predetermined understanding that it's less eplet based on what you were saying, or other immune characteristics, right, that I would require less immune suppression. Should those factors sort of be considered as we allocate organs, like all the way at the beginning of the process, rather than we've given you the organ, now we're trying to help you keep it as long as possible? Does that make sense?
It does, and it's a very great question, because we're in a situation now, and I don't know how much your audience knows about the new IOTA, improving organ transplant access laws by Medicare. We're participating in that, and there's certainly financial consequences for centers who do not transplant enough patients or fall below expectations. You have to give money back to the federal government. So the federal government wants us to transplant as many people as possible. And I think that's an admirable goal. Now, we have been very active in this and trying to improve access for our patients. We've been doing work with complement blockers, C1 inhibitor. In our last study, we used put the drug into the kidney, and we found that in a placebo-controlled trial that we could improve long-term outcomes in these kidneys. So, last year there were about 7,000 kidneys discarded, because primarily many for good reason, but many of them probably could have, more than half could have been used. There were also about 6,700 people dying waiting for a kidney. So this is the crux of it. If you don't want to get too picayune, so to speak, about matching, I think we can modify that. And again, when we look at our situation with patients that we use this, Bella IL-6 end, even though there are very few, these are highly sensitized patients, high risk for rejection, and we're getting by with that. So I think if we have that kind of protocol, we can bypass that sort of situation. And obviously you want to get as good match as possible. It's just not always possible. And we want to transplant as many people as possible, because their lifespan on dialysis is not very good.
Jordan, we are very sad to say our time is just about up. Thank you so much for coming on the show here and sharing your expertise with us. I know I learned a tremendous amount. I'm sure our listeners did as well. So thank you so much for joining us on the show.
It's my pleasure. I'm really excited about this.
Thank you, sir.
Welcome back. It is time for the tea, and the tea is caliente today. The tea comes to us from an anonymous listener who has asked, I have heard webinars about a new serologic nomenclature system, and that system is WHO approved, but that system is not yet present in IMGT, nor noted as being the official WHO nomenclature. Should we start to use the new system? Or are we bound by regulation to use the existing / old nomenclature system until it is live in IMGT?
Yeah,
That is a loaded question.
You said caliente, but what's hotter than that?
Caliente, muy caliente.
Yeah, okay, thank you.
It's
Right.
muy
I mean, I think that I see both sides of this coin, right? I mean, I think I can see why you would want to use it, and how that can be a more beneficial, modern application of the nomenclature system, if you will. I can also see the other side of that coin being that without it being sort of official in its capacity and whatever that means, why groups would be hesitant to do it. And so it's not really an answer to the question. I think it depends on the situation. It depends on the patient the pair that's being evaluated and what is going on, right? What kind of antibodies, what kind of mismatches are there, how you would want to use that. I think I would say you would want to have some sort of like documentation, justification as to like your logic. It's sort of been our bread and butter of if you're going to like take a veer down some alley, at least provide some sort of like tippy tappy, this is why I'm doing this, for future self-reference. Because if you're like me, I'm not going to remember 5 minutes from now. You?
Yeah, I think part of what you said is so important, like documentation. I know that there are folks that are already putting it into practice, and most of those folks are doing it from like a Robin Hood patient safety perspective.
Sure.
If we have data that says that this HLA allele is serologically, antibody reactivity wise, more like this thing than what it's currently being called, is that potentially a patient safety issue? Absolutely. That concern is real, and the data in those publications would say it's a legitimate concern. On the other hand, CLIA, ASHI, CAP, the regulatory powers that be in the United States certainly say you must report WHO nomenclature, and what is out there as official WHO nomenclature right now is the old thing. So it puts laboratories in, quite frankly, like a catch-22.
Yeah.
So I think if you're going to report the new nomenclature, which is somewhat against what regulations say you have to do, you can put an asterisk on your report that says, WHO nomenclature currently calls this XYZ. I am calling it this, reference this publication, as it's known that this is approved. It just hasn't been finalized or made official yet. Or if you're on the flip side and you're procuring a donor from an HLA contract lab with an OPO that has used the new nomenclature, but you don't feel comfortable using the new nomenclature for regulatory purposes, you could call it the old thing, but put a statement on your reports. This publication is going to reclassify this item as this thing. And when you're looking for DSA, look for the new thing and the old thing, and document. Labs are kind of in a tough space here, and everybody's trying to do the right thing. I think the right thing is to document.
Yeah, and I think the right thing is, come on, WHO.
Come on, WHO, put it out, just put it in
let's-
IGT. Just
let's
put it out
just
there, man.
wrap it up here, man.
Let's do it.
That's what we're all hoping for, to be
Yeah.
honest with you.
Yeah. I think that the investigators and collaborators on that work have some great evidence. They've come up with a system for us to utilize their evidence-based approach. I think we're all just kind of in purgatory, waiting for something to happen one way or the other. So, dear listener, that is the best that Dr. Weimer and I can do for you. Thank you for this outstanding question. And don't forget, if you need career advice or advice on how to deal with something happening in your lab, please visit our podcast page at ashi-hla.org/page/Ashi podcast, or you can email us at info@ashi-hla.org and write the TEA in the subject line, and subscribe to our YouTube channel.
Hey there, Coffee and Compatibility listeners. Do you have a technologist that you'd like to spotlight? Nominate them by sharing their story with us. Email us at info@ashi-hla.org for a chance to feature them in an upcoming episode of Coffee and Compatibility. Don't go anywhere. We'll be back in just a few moments to recap our thoughts on today's episode.
I was just thinking about my casual conversation with Stan just
I thought you
now.
might still be in awe.
I am.
I mean, so much awe that we lost Jeremy.
Right. No, actually, dear listeners, the only thing that could separate Jeremy from you and finishing recording this podcast is the fact that his lab is right now being inspected by CLIA.
Bum, bum, bum.
So if Jeremy is not here and CLIA needed him like right now, so he wanted us to make his apologies, but he had to go deal with an inspection in CLIA. Totally understandable. But yeah, today's episode, outstanding. And like for all the exciting stuff that was talked about in today's episode, Dr. Stanley also relayed to us that a new area of research for him, really important in the immediate post-transplant space for all patients, I am sure, are these studies that he's doing with antigens, donor antigens being expelled post-transplant in exosomes, and the involvement of complement C3 molecules in that process. If you are going to be at the World Transplant Congress this year, or if you are a reader of the American Journal of Transplantation, all of this will be there, and Dr. Jordan will be there. So stay tuned, because I think that story is going to be outstanding.
Yeah, I can't wait to see what comes of all of that. And something that sticks with me from our conversation with Dr. Jordan is the need for HLA labs to continue to evolve, which feels like a theme that we've touched on repeatedly in the near recent episodes that we've done. And he talked about a number of like immune monitoring based assays, T regulatory, T cell subsets, etc. were mentioned. And as we as the community think of the future and where our role is as some of these immune modulatory desensitization protocols become like standard of care and are more globally utilized, I think we need to continue to think about how we can support better stratification and more personalized approaches rather than just do donor specific antibody testing and that's it.
Yeah, you're totally. Yeah, I mean, we need to diversify, not just honestly like for relevance and expertise to continue on, right?
Yeah.
But to provide optimal care for our patients and our clinical partners and clients. I can't tell you, like, I mean, this dates me, but I'm aging gracefully, that like in my basic science life, we did MLRs all the time, mixed lymphocyte responses all the time. But in a clinical setting, they are very rarely applied. And yes, they are time consuming. You have to have all of the facilities necessary to follow aseptic technique and have culture environments. But how many times on a pretty weekly basis have I thought to myself, man, what right arm I would give to be able to do an MLR on this patient to see what's going on? Yeah. So like, it's like some of these things are new and we need to diversify, but they're kind of old.
Oh, yeah.
But there are other things, like he mentioned donor-derived cell-free DNA, which is going to become more available to labs. You know, looking more at T cell and B cell repertoires.
Yep.
Yeah, we got to diversify.
Well, and I think you touched on really the point, right? It's not just doing it for doing its sake, right? Or justifying your own existence. It's that, you know, there's very few areas within medicine where the transplantation knowledge is so concentrated within like the community as at large, right? And being able to do, like, we oversee flow cytometry here at UNC Chapel Hill, right? But we don't do immune T cell subsets or a number of other like immune modulatory monitoring things for many reasons that you would come up with, but we should, right? And it's because the expertise and who's going to do it right and understand how to interpret it in the context of, you know, immune modulation, the donor specific antibodies, their cell-free DNA results, all things that like are in the wheelhouse, if you will, of ASHI labs and ASHI members. And so I think it's important that, you know, we keep in touch and we monitor how the field of large that Dr. Jordan is working on continues to evolve so that we can make sure we're providing high quality testing for those cases, right? Because honestly, if we don't do it, someone else is going to do it. And that doesn't seem like a great situation for the patients, losing that expertise connection. So, you know, I hope the listeners take this to heart and we, you know, as a community, continue the conversation of what, you know, we can and should be evolving towards. You know, it's always moving.
Absolutely, as is Dr. Jordan and his work. Look out, folks. Like, I mean, Dr. Jordan is an ASHI honoree, for clear, obvious purposes. But he is not slowing down anytime soon. His work is going in some really interesting areas. So keep your eyes peeled, for stuff from Dr. Jordan and his collaborators.
Awesome. Until next time, guys. Bye.